Okay. Um, Thanks for the nice introduction. The books issue, my excuse is that my father was a journalist. So I think I inherited some genes from him. And of course, books are very collaborative things, and collaboration is something which I enjoy very much. Um, Look, it's great to join this group, and I should pay tribute to one of your colleagues in Canada, Mary Seaman, because I think Lena originally got my name through Mary, and Mary is really one of my heroes. She was a major pioneer in terms of promoting women's mental health and understanding women with schizophrenia, and made a lot of very important contributions throughout her career. In fact, she's still active, as you would know. Um, Notably, that women's requirements, women with schizophrenia requirements for medication are very different from men, and we base our evidence base on men basically, and usually youngish men. So women, and especially older women, their requirements for and doses of medications change quite dramatically. So I'd just like to pay tribute to her. This is a talk which has the following structure, and as is always, there we go. So I'm going to talk a bit about history. As I get older, I enjoy the history more and more, and it's always important to remind ourselves of the history and how we've got to where we've got with respect to understanding things like schizophrenia, and also some curiosities within the nosology around a definition which actually prejudices against women in terms of diagnosis of schizophrenia in particular, and especially later onset women. So I'll talk about this as we go, but I think it's both interesting and also important in terms of understanding the literature. Because if you look back at a lot of studies, they actually simply excluded women with later onset. And people like Mary Seaman, Dilip Jesti, of course, in the States, Peter Ravens, have put this later onset schizophrenia back in the map. In fact, Peter had an article, 30 years ago maybe, saying, does late onset schizophrenia exist, A bit about epidemiology. I started off, as Lena was saying, as an epidemiologist in psychiatry, and I worked with a register in the UK, which was unique in the sense that it managed to collect over a period of about 20 years anybody with a non-affective psychosis. This was set up at the Institute of Psychiatry. It's still a very rich source of information. And we were able to track uniquely, just not the 20-year trends, which were important in themselves, but we were able to go up to the very late onsets. So it didn't prejudice against the late onsets. It included everyone with a non-affective psychosis, and also didn't fall into the trap, which is a real big trap in epidemiology, in my view, is collecting people only with DSM-defined schizophrenia, because DSM-defined schizophrenia is, in my view, only a subtype of what schizophrenia really is. So I'll talk more about that. Because of the topic and because of your guys' interest, as far as I understand it, gender differences is something I'll dwell on. In most books and articles around schizophrenia have many more men and a more of an accent on men. So today we'll talk mostly about women. Phenomenology is so interesting, and again, I don't know how, I think you guys in Canada hopefully hang on to some of the older traditions of teaching phenomenology well. Certainly we've lost a lot of that in Australia, to my regret, because I think phenomenology is so fascinating, but also instructive. Talk about risk factors, a bit about neuropsychology and brain abnormalities, and then I'll end with treatment and an attempt at an integration or interpretation. And I have a certain view about certain aspects of all of this, which I'll share with you. Of course, I'm very willing to be contradicted or for questions to question my particular view because it's not necessarily correct. So here runs the history. Kraepelin, sorry, incorrectly spelled on the slide. I have a lot of respect for Kraepelin. In Australia and Canada as well, you've had a lot of investment in early intervention, and you know, I think the early interventionists here in Melbourne in particular sort of do a lot of Kraepelin bashing. They say Kraepelin talked about schizophrenia being a poor outcome disorder, and we need to be more positive about it. Well, actually, they're wrong, because Kraepelin never really said that. Kraepelin defined dementia precox. He didn't define schizophrenia. He was very well aware that schizophrenia, as we know it, was a pleomorphic group of disorders. And as you know, he emphasized longitudinal deterioration as being a hallmark of dementia precox. Now, if you look overall at the dementia precox type patients, they are only maybe 40% of people who would have schizophrenia under DSM terms. And they're essentially an early onset male predominant poor outcome group. I think they're the neurodevelopmental schizophrenias with early adversity to the brain. Males are more vulnerable to all neurodevelopmental diversity and mental. I'm not sure what terms you use, but dual disability, we call it, with intellectual impairment plus schizophrenia. The terminology keeps on changing because and political correctness. So I'm sorry if I'm using the wrong terms for your part of the world. Intellectual disability in and of itself, male predominant, autism, male predominant, and also they're all left hemisphere predominant. And if you think about schizophrenia and language, and Lena was very fortunate to work with another peer of mine, Peter Little, who talks a lot about these things. And we'll come back and talk about Peter Little, actually. So you just remind yourselves, and I keep on reminding people, Kraepelin, dementia precox, early onset, male predominant, left hemisphere problem, disorder with a poor outcome. The paraphrenias, what he called paraphrenias, actually had a much better outcome, and he was aware of this group. And he also knew that there were other groupings as well, and he was quite open about that. Paraphrenias, it becomes quite complicated historically because the terminology keeps on changing. Paraphrenia was a term actually used by Kraepelin, and I think my reading of it, and I can't read him in the original German, unfortunately, but my reading of him in translation, it seems that these later onset paraphrenias, as he called them, are more akin to what we would have called paranoid schizophrenia. And for those of you who remember before the DSM obliterated subtypes, paranoid type schizophrenia tended to have a later onset, tend to have a better outcome, tended to have better preservation of affect, tended to have more females. So Martin Roth, in a seminal paper in 1955, took the term paraphrenia, called it late paraphrenia, and described a group of people who have an onset usually after the age of 60. Now, of course, in those days, you would have been saying, well, I'm sure most of those people either have late onset affective disorders or else they're dementing. So he did a very important study, which was a longitudinal study, follow-up study, and showed that in fact, most of these people with late paraphrenia didn't necessarily dement. And he compared them to people with dementia. So that was a very important contribution, because one tended, as I said, to associate in one's mind late onset psychotic symptomatology with dementia. And of course it happens, and it's not uncommon in dementia, but there are these group of late paraphrenia, what he called late paraphrenia, who don't dement. What was happening on the other side of the Atlantic, so Martin Roth, of course, working in Newcastle and very influential in mood disorders as well. On the other side of the Atlantic, the finer criteria for schizophrenia had come out. There's an interesting history as well from the US-UK diagnostic project. And finer criteria are very intriguing if you read them in detail, because he actually defined schizophrenia not exclusively under 40, but having an onset under the age of 40. Why 40? Well, I don't know. Nobody really knows why it was 40. It was defining, it was one of the definitional terms. It wasn't an exclusive term, but it gave you more likelihood of getting a diagnosis of schizophrenia under his rubric. So there again, if you look at Kraepelin and you look at Feiner, they're starting to define something which is not dissimilar and quite different from late paraphrenia. ICD, which is International Classification of Disorders, in its 9th revision, which was in the 70s, it's only just released its 11th edition, introduced the term paraphrenia, which was Kraepelin's original term, and used that for defining what Roth had called late paraphrenia. So as I said, it becomes a bit complicated. My very good friend and colleague Rob Howard, who I worked with in the UK, and then we had a beautiful conference in Leeds Castle in Kent with people like Nancy Andreasen and Peter Rabins and all the who's who of the schizophrenia field. We actually adopted a different term, which was called very late onset schizophrenia like psychosis. Bit of a mouthful, but that tends to be the preferred term for these very late onset groups of individuals. DSM-3, and DSM is pretty pervasively influential in Australia, and I'm sure very pervasively influential, for better or worse, in your neck of the woods. I think, as most people would agree, it's a problematic nosology, and some of the problems associated with was it made some decisions which were quite difficult to justify. DSM-3 defined schizophrenia as having an onset under 45, and that then led people like Peter Rabins to write articles to say, so is there a late onset schizophrenia? Well, there is a late onset schizophrenia. I hope I will compel you about that. And happily, in later editions of DSM, they have abandoned the age cutoff, but there's still, in clinicians and researchers' minds, this notion that basically schizophrenia is an early onset illness. So that's some of the history about the nosology from ICD and from DSM. Let's look at it through a different lens, and that is sort of purer epidemiology, which is actually going to individuals in the community and asking them about whether they have paranoid beliefs. It's a bit of a curious set of studies to do, isn't it? I mean, if you are an elderly person living in your little cottage and are quite paranoid, and someone rather official looking comes and knocks on your door, I think the likelihood of you answering the door is probably quite low. So you've got to take these studies with those caveats. Christensen and Blaze, a very important work in the 80s, looked at quite a big group of people over 65. About 4% of them had persecutory ideation. By the way, just for the record, of course, we know that all of the psychotic phenomena don't just occur in psychotic disorders, that quite a fair proportion of the general population have either mild paranoid ideas, referential ideas, some hallucinatory experiences, and this is sort of psychosis proneness notion championed by people like Jim Van Os. But this study showed 4% of persecutory ideation in elderly people. Scott Henderson, who again a close colleague initially from the UK, but been in Australia for very many years, looked also at about 1,000 people over 70, and then looked at the psychotic people with psychotic phenomena, and then very importantly looked at how many of those were associated with cognitive deficit. So again, teasing at this issue about, are these all associated with brain maladies like dementia. And then Forsell and Henderson in the 90s also looking at a bigger sample and coming up with not dissimilar rates, so 4 to 6%. Prevalence studies, a nice one in Wales, show actually looking for late paraphrenia. So the studies I've just shown you were of persecutory ideation quite broadly, without prejudice as to diagnosis. These studies are of specific paranoid psychotic disorders, and sometimes they're called late paraphrenia and sometimes they're called schizophrenia. And the one at the bottom is probably the most instructive. It's from Copeland, who's a very big name in the field as well. And they did a very sophisticated study and specifically diagnosed schizophrenia according to DSM-3 terms. And remember, I've said DSM-3 said you couldn't get it under over 45. They just scrapped that criterion and showed that about 1.12% of people with schizophrenia had this very late onset. And then Harris and Dilip Jesti in the 80s did what became a very celebrated review of this literature. And this was a time of DSM-3 thinking, and people didn't believe in late onset schizophrenia, at least on that side of the Atlantic. But they made this point very clearly that a lot of people actually, well, substantial minority of people had late onset, and some of them very late onset. Dilip works in mostly settings with a lot of the veterans hospitals and so forth, VA hospitals. So it doesn't have very late onsets, but in his epidemiological work has acknowledged that 3% of people with schizophrenia have an onset after the age of 60. So the points I'm trying to make here are late onset schizophrenia exists. There have been attempts by DSM in particular to simply operationalize it out of existence, which happily has not prevailed. So I'll turn to some of my own work, and this was the basis of my doctoral thesis. I studied at the Institute, as Lena said, in London, and with Robin Murray and Rob Howard and others. So I was very fortunate to have that sort of level of academic rigor behind me. And we looked at 500 people. At the time, it seemed like a massive sample, but it's actually rather small by today's standards. But one of the virtues of the Maudsley Hospital and Institute of Psychiatry in London was fastidious note-taking. And we had all the notes. So I spent a year of my life going through case notes and recoding all the mental states and histories into an operational criteria checklist, which had been developed by Peter McGuffin and Anne Farmer. And the one thing about the Maudsley was the note-taking was impeccable. And it was quite interesting, reading notes which had been made in the middle of the night by, now Sir Robin Murray or Michael Shepherd or other people. It was quite fun. But I was able to extract very good information on practically all of the patients. And we then entered them into this operational criteria checklist, which is linked to a computer algorithm which allows you to generate any type of diagnosis you like. The other virtue of it is you can actually look at the phenomena themselves, and so you could look at Schneiderian first-rank symptoms if you wanted. And we also the register, which had been set up in the early 60s, had, as I said at the outset, the great virtue of not having age cutoffs. They took any first episode non-affective psychosis, basically. And we found a rate of non-affective psychosis in the elderly, and this is one of the few incidence studies of 12.6 per 100,000. And then I started getting very interested in gender differences, and I know that's one of the interests of this group. And this is how it looks. So the males in the light blue bars and the females in the darker blue bars, and you can see the spread. And what I hope is quite obvious to you is the distributions are different between the sexes. So males, you have this very big early onset peak, which is, I think, dementia precox, neurodevelopmental type schizophrenia. Females get it, but are less vulnerable to it. When they get it, they can get it very severely, of course, but they're less vulnerable to it overall, and that speaks to the epidemiology from what I've shared before. You do, however, in females get a second sort of peak in midlife. Some people have made the association with the menopause and said, oh, it's all estrogens. I think that's only a very small part of it, partly because males also get a midlife peak, and also because nobody's actually at an epidemiological level managed to look at the strong, whether there is a proximal or temporal association between estrogen levels and estrogen decline in menopause and the onset of psychosis. Of course, we know estrogens have dopaminergic blocking properties and do have antipsychotic effects. Jayashri Kulkarni in Melbourne done some nice work on this. And people like Heinz Hafner, of course, in Mannheim. But the point of it is, to my mind, that's not the whole answer, because males also get it. The other thing is, if you look in the right-hand part of this graphic, the female resurgence of yet another group of onsets after the age of 60. And that's what I've been alluding to as I've gone through this talk so far. Now, what do you do? How does that look if you convert raw numbers into rates? So the nice thing about this study was we were able to look at the population, the general population, and then determine rates by age. And that comes out in this way. This is males and females combined, and it takes DSM-3R defined schizophrenia, so that's DSM-3 similar, but without the age cutoff, and also broadly defined schizophrenia. So broadly defined schizophrenia is schizophrenia-related disorders, which is throwing them all into the mix. And you can see once you start applying the DSM more stringent definitions, you really get an exacerbation or overemphasis of this early onset peak, but also of the late onset peak. So they meet criteria under DSM. This is a different study from the Camberwell study, and I'm just showing it just for comparison. This is from a study which we conducted in Australia 2010. It's called the Study of High Impact Psychosis. It's actually a very good epidemiological study of people within treatment for psychotic disorders. And we also try to be pretty broad about the inclusion criteria. But unfortunately, we couldn't collect people over the age of 60. Reasons for that include the fact that our services are truncated at 60, and then you move into old age services. That is one reason. The other thing is you start getting conflated with cognitive decline problems and dementia. So for pragmatic reasons, we didn't include the very late onsets. But even here, you can see the female smaller early peak, and then the later the sort of middle life peak. Here it's earlier than in a lot of other studies, but it just shows, there's not just the Camberwell data set showing this. So I've alluded to this throughout, is the female excess. And we can talk a bit about why that is, and I'm sure you'd have views, but my own view, as I've probably made clear already, is I believe that these are males and females are vulnerable to different subtypes of schizophrenia, or schizophrenia as we call it. They're different disease entities. Males particularly vulnerable to early onset neurodevelopmental subtype. Females more vulnerable to the very late onset, late paraphrenia or very late onset schizophrenia like psychosis subtype. Why might that be? well, as I said, males are vulnerable through their brain to neurodevelopmental disorders across the board, and that includes the ones I've alluded to already. David Taylor, who's a neurologist, wrote a lot in the 70s about left hemisphere development, and he made the point about the vulnerability in males to left hemisphere problems, partly because testosterone starts to be secreted by the testes at about 12 weeks of gestation and impacts brain development, ironically through estrogen receptors largely. And that slows male left hemisphere development, makes it more vulnerable to insult of any kind. So that might be one factor. I think it is an important factor. Males are more vulnerable to obstetric complications and other things which have been associated with early onset neurodevelopmental schizophrenia. And why then the very late onsets? Well, again, it's way beyond menopause, so it's not just estrogen, although estrogen might have some protective effect. My stab at this has been that if you look at the male and female brain, dopamine receptors have very different trajectories over time. So males start off with more dopamine receptors generally, but lose them quicker than females. So females hang on to their dopamine receptors in their brain until later life. That might be a reason that they're vulnerable to late onset or very late onset schizophrenia. Might also be a reason why they're more likely to have tardive dyskinesia, for example. I mean, these are very long bows that I'm drawing, but try to make some sense of why there's this differential vulnerability of male and female. Because you can see here one thing which is very, 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 very consistent within the literature is the female predominance in the late onset group. And this just shows it again, however you look at it and whatever definitions you use, you will find females vastly outnumber. So what we then did with the Camberwell Register data was to pick up on this and got particularly interested and exercised about the female excess. And I had the privilege of working with Pak Sham, who's now in Hong Kong and very clever statistician. And we managed to subject the data we had to admixture analysis. And what we showed basically was that there were indeed in females and males differential distributions, which is pretty obvious, I suppose, looking at this graphic. But if you actually look at it statistically, you can actually show that males have these two peaks and females, the male in blue and red, and the females have three peaks with modes at 22. So that coincides with the dementia precox peak of the early onsets, but as I said earlier, that's a more male disorder, and this midlife peak, and then the very late onset peak. So this was a very nice outcome in terms of our data. Again, to reinforce, it's not just our data which is showing this. This is not dissimilar outcomes using slightly different statistical technique with a bigger sample from McLaughlin and John McGrath and other excellent psychiatric epidemiologists in Australia. And this is for the females, and you can see again their very late onset group. So I'm going to move a little from phenomenology, from epidemiology to phenomenology. As I said, I was very fortunate with the Camberwell Register series to be able to look at phenomenology in great detail and to then operationalize all these definitions. And what I've done here is to just present for you the very early onset patients, so under 25 because that's sort of generally accepted as youth, pretty much what almost all of Kraepelin's dementia precox cases onset before the age of 25, and then compared those with the proportion of the particular phenomena in the very late onset group. And a couple of striking things here. One is that thought disorder, and by that I'm talking about formal thought disorder, and again, we owe to Peter Little some of the understanding of this. You know, he talked about positive and negative, or reality distortion, and so forth. But he also made the point about formal thought disorder being a different dimension. Funnily enough, in Little's nosology, it runs with inappropriate affect, which maybe was a little bit unexpected. But what we're seeing here is these formal thought disorder, so disorders of the form of thought, common in the early onset group, but very, very rare in the late onset group. Then we look at negative symptoms like restriction of affect. And again, that was a very different, people with very late onset schizophrenia just don't get negative symptoms. So restriction of affect, which would be a core Bleuler'ian negative symptom, if you want to go back to Bleuler, shows, you know, not uncommon in early onset. In fact, 17.9% to be exact in the sample. But the late onsets just don't get negative symptoms. Some of the Schneiderian first rank symptoms, also thought insertion, withdrawal, and grandiosity, rather more common in the early onsets. But the later onset patients had a very strong likelihood of having persecutory delusions, organized delusion, widespread delusions, and also hallucinations, and often in multiple modalities. I don't know how many of you might have worked in old age psychiatry and have experience of these patients, but I happen to have worked with quite a few of them, and it's a very striking clinical picture. Usually quite long standing before they come to attention of services. These florid, very widespread belief systems of a paranoid and persecutory nature, and then hallucinatory experiences to go along with that. And often hallucinations actually in a lot of different modalities. And there are some particular ones which are intriguing, things like, you know, olfactory, very common. So one of the beliefs, and I'll show you a slide to show this shortly, is related to a particular type of delusion called partition delusions. Partition delusions are where impermeable barriers have been transgressed in some way by, you know, in a way which would be impossible. So, for example, people coming through your wall or getting through your ceiling and coming into your home at night. And I remember going to a lady in one of the tower blocks in London, and she only very reluctantly let us in, but she then started telling us about the neighbors and how they were pumping gas into her apartment, and she could actually smell the gas at night. And then she rolled back the carpet and showed us all these little marks on the floor showing exactly where these people had been, and they trod there in the middle of the night. There was nothing to see, but she was obviously had a belief system around that. So these widespread, persistent, paranoid belief systems, partition delusions, and multiple modality hallucinosis. This is a slide I borrowed from Rob Howard. This is partition delusions come true. This is a way in which the British police can get into your house. So you can imagine a poor little paranoid old lady in your apartment, and suddenly someone comes with this machine which actually allows them to break down your entire door or your entire wall and come in. That's true partition delusions. Okay. So that's about the phenomenology. What about the risk factors? Well, people with late onset disorders also have a genetic predisposition to schizophrenia, of course, but they also have genetic predisposition to other things. And we did a study looking at this again in London with Rob Howard, and showed a loading not just for schizophrenia, but also for mood disorders. one of the very few reasonably well-conducted family studies. Sensory impairment is fascinating. Both visual and auditory impairment. And Dilip Jesti then did some nice work showing that it was uncorrected sensory impairment. So if you had poor eyesight and hadn't gone and get your glasses checked and reissued, that was the reason you were more likely to have visual phenomena. And poor hearing associated with auditory hallucinosis mostly. Of course, that's also been shown in younger onset schizophrenia, but it's rarer in younger onsets because of youth. Premorbid personality is interesting. So as you'll be aware, in people with younger onset schizophrenia often have some sort of personality traits, maybe schizotypy and so forth. In the later onsets, they're mostly paranoid personality types and very socially isolated, but usually not educationally or vocationally impaired. So they'd usually have pretty good trajectories in terms of that. We looked at that in the Camel Register, again, the very early onsets and the very late onsets, and you can see family history of schizophrenia did occur in the late onsets, but much more common in the early onsets. Things like obstetric complications, the sort of neurodevelopmental risk factor markers, and developmental delay, much more common in the early onsets, as you would expect. Poor premorbid adjustment, much more common in the early onsets. Marriage, there's a little quip about this. I don't know how true it is that marriage is good for the mental health of men, but not very good for the mental health of women. Across the board, of course, I'm sure everyone on the webinar are exceptions. The people with late onset schizophrenia, actually quite a lot of them had been married. Of course, these were different eras. This was in the people who were growing up in the early 20th century. So maybe it was more common that you'd get married anyway. So sort of coming to some conclusions and closure, I just wanted to talk about the neuropsychological impairments. So Osvaldo Almeida, who now lives in Perth in Western Australia, when he was also in London with us, did some work looking at 40 people with late paraphrenia. I should say research in late paraphrenia is quite tricky because although they certainly exist, they're relatively rare. And I'll show you data shortly to show how exasperating it can be to do trials with this group of patients. And he looked at 40 of them, which is not a bad sample, and 33 age match control, and they were matched on the NART. The NART is the National Adult Reading Test. It asks you to read out a number of words, and is meant to be a proxy sort of marker of pre-morbid IQ. And it's very common to match in these sort of samples. And he did quite an extensive battery, mostly with the CAN-TAB and the WAIS, and found a pattern of cognitive impairment similar to those described in, but different from Alzheimer's and Lewy body dementia, in that they tended to preserve learning. So cognitively, they were not impaired in the same way as people with these dementias. Especially, well, Lewy body dementia is an interesting one because, of course, that commonly has psychotic phenomena associated. Of course, Alzheimer's disease can as well, but the Lewy body one's often more prominent. Turning to your side of the Atlantic, Godfrey Pearlson was one of the people at Hopkins then working on this, and did some brain imaging studies. And of course, there was a plethora of brain imaging going on in those days, and still is, of course, but mostly early onset male predominant schizophrenia. So looking at these very late onset groups and comparing them, they showed white matter abnormalities. Early studies of late onset schizophrenia found very extensive white matter changes across the board. It was not in the days, most of these studies before we were sophisticated enough to do things like DTI and so forth, but just just a sort of visual of the brain. That then led to people saying, oh, well, it's a type of dementia. Actually, if you go back and you match for cognition, you match your samples properly, the white matter excess really is largely driven by cognitive, associated with cognitive abnormalities. So if you exclude those patients, there's not such a big excess. And also if you match for cognitive, for cardiovascular risk factors. So it was almost certainly an artifact of that. Structural abnormalities of CT and MRI showing abnormalities very similar to early onset. Some of them had progressive degeneration. So some of these people have been followed up, and some of them undoubtedly develop a dementia, but it's not all of them, and it's relatively rare. Okay, so again, that goes back to Martin Roth's 1955 study to show that these are different from the dementias. I'll finish with talking a bit about treatment, because they're actually very difficult to treat. I told you about the patient in the Tower block we had to go and visit, and there was no way in the world she was believing that this was because she was mentally ill, and there was no way in the world she was going to accept any medication from us, because she believed we were just going to poison her, and that became part of her paranoid delusional system. So what do you do? Well, there's so little evidence, or good evidence. Rob Howard looked at this, and in those days there was very little, nothing in the Cochrane review at all. There was one naturalistic observation of flufenazine decanoate, and actually some people would argue that using long-acting injectables, not flufenazine, I guess now, we'd probably use aripiprazole long-acting, or paliperidone long-acting, at quite low dose, probably the way to go because of the adherence problem. The consensus in the US was low-dose risperidone. I mean, that is a teeny dose. Of course, there's caveats with all of the antipsychotics and black box warnings about cardiovascular, cerebrovascular risk factors in using these agents in the elderly. But it's always the balance between whether you can get people less paranoid and more integrated in society and happier, and then there's a slight increase in their cerebrovascular risk. Well, we make those sort of clinical judgments every day, don't we? And then a trial, an open trial using 100 milligrams of amisulpride. Now, I'm not sure if you have amisulpride in Canada. I know in the States they don't. Amisulpride's a curious drug. It's what Stefan Loich calls the atypical, because of all of the atypicals, pretty much all of them have 5-HT2A receptor blockade to counterbalance the D2 blockade. Amisulpride doesn't. Amisulpride is essentially a pure D2, D3 blocker. Actually, no, that's not quite true. It has some 5-HT7 blockade as well, which might be relevant to cognitive dysfunction. But essentially, D2, D3 blocker, very widely used in Europe. Usually, and what people don't understand about it is it acts rather differently at low and high dose. At low dose, it acts mostly presynaptically and is associated with dopamine release. Postsynaptic blockade occurs usually above about 300 milligrams a day. In the elderly, though, they're tending to use tiny doses, 100 milligrams a day, and it seems to be reasonably effective. And this is from the Soros study, 5 weeks of 100 milligrams of amisulpride, and you're getting very nice reductions in your BPRS scores, which is positive symptoms, improvement quite dramatic in your CGI. So I'm going to finish with Rob Howard's study, Atlas, published in Lancet Psychiatry. He lent me this slide because he was a guest speaker at one of our conferences in 2016. And by that time, he was completely exasperated that they had initially aimed for 300 patients in this trial. They were going to do that in 2 years. By the time he was speaking to us in 2016, it was a good 4 years, and they had only reached 83 patients within their recruitment, and they were projected to take about another year to actually ascertain all their patients, but they carried on, and at the end of the day had a very impressive study. And this was placebo versus 100 milligrams of amisulpride. And one of the things which they have done, and which I think is very important in therapy with these individuals, is you've got to nuance yourself very carefully. And they had a lot of refusals, even though using the sort of nuanced engagement process. Very much not confrontational, really trying to get alongside. A lot of what we would be saying to these patients is, all of these awful things happen to you, and all the distress and the fact that you're not sleeping at night. Maybe I can give you some medication to help you with some of the distress which you're feeling, for example, rather than, to take away the voices because you have schizophrenia. That is sort of collaborative exploration of particular treatment targets, and trying to get people engaged with that. You can see here the numbers who actually ended up participating and staying within the study. There's quite a lot of fall off, but nevertheless the results were pretty compelling. The BPRS improvement at 12 weeks was 11 points with the amisulpride, 4 points with placebo, with a large mean difference of nearly 8 points. And also what they did then was to offer an extension, and those ones who stayed on amisulpride continued to stay pretty well. And actually not massive side effects. As I said, it's a very low dose of amisulpride. Usually in adults you're using 4 to 8 to 1200 milligrams. So we're using teeny doses here, and a lot of the serious adverse events were actually not seemingly related to the medication. So I'll leave this as a last slide, saying, coming back to what I said at the beginning, schizophrenia, I think all of us would agree, it's fundamentally heterogeneous. For us to talk about schizophrenia as an entity, I think is misleading for ourselves and for the field. Late onset schizophrenia, I hope I've compelled you, undoubtedly exists. And that's also heterogeneous, and there's a small subgroup within those who progress to dementia, but a lot of them don't. It's a combination of risk factors, but they're quite different. The late onsets and the early onsets, lower genetic risk of schizophrenia, but also lower insult burden from neurodevelopmental insults. And antipsychotics work, but the low dose needed and adherence is the major challenge. Now, you get a prize if you know who these people are. One on the left is Catherine Zeta-Jones. This is not true, by the way. And the one on the right is an Australian actress called, all of us are aging at exactly the same rate, even as we listen to this. So thank you so much for your attention, and I'm happy to take any questions or comments, and I'll stop sharing so we can get into gallery view.
Thank you very much, David. It was a fantastic, very interesting talk. There's quite a lot of material you covered in the last 60 minutes. I'm sure people have a lot of questions. I have some on the chat box already, so let me start with some of them here. I will read them out, but if you want to look at them, you can see in the chat box as well. The first question is from Sean Hughes. He's a senior resident in the psychiatry program here. So the question is, just following upon your conclusion, David, do you believe that very late onset schizophrenia should be recognized as a different subtype of schizophrenia, or should it be reconceptualized as a different psychotic disorder with its own different entity in DSM? What is your thoughts on that?
Yeah, look, it's a really good point. I suppose the world is largely grouped into lumpers and splitters, aren't we? So you could take the view that, well, psychotic phenomena, like most other things, are pretty much normally distributed within the general population. 10 to 15% of the general population have psychotic phenomena at time in their lives. We should just say, well, we'll look at it dimensionally, and then we'll take the extreme end of the Gaussian curve and say, well, they have a disorder. That's one way to go. Another way to go would be to say, well, let's try and really tack into defining that extreme end of the Gaussian curve and carving it up into little bits. The DSM until DSM-5 had subtypes of schizophrenia. Were they helpful? Clinically, actually, some of them were. I think, especially the paranoid type, they tend to be different, I think. As I said, later onset, better outcome, better preservation of affect, probably less cognitive impairment and so forth. Is it useful recognizing that? Could argue it is. Does it make a real big difference at the individual patient level? Absolutely. But that's not to say you need to have the label of a paranoid as opposed to a hebephrenic type of schizophrenia to really do the best by your patients. So my answer to these questions always at the end of the day is, if you're a clinician, and I still do a lot of clinical work, you really come back to the individual and you say, what is your particular symptom set, and what is your particular set of circumstances, and what is your particular set of strengths, and what is your particular set of vulnerabilities, and how do we work with that to get you the best outcome, right? At an epidemiological level, or if you're recruiting for a clinical trial, should you be wedded to diagnostic criteria? Well, they have the virtue, if you use the diagnostic criteria, of being rather more reliable, of course, which is important in science. However, as you will be aware, even schizophrenia within the DSM nosology doesn't have very good validity. And even its reliability is actually not that brilliant. Then would you say, well, if you were working in the field of very late onset schizophrenia, should you be using a different set of criteria from early onset schizophrenia? Because most of the studies have just said, well, we'll take the early onset schizophrenia criteria and just apply those, but remove any age constrictions. There might be a problem with that because, as I said, the spread of phenomena are rather different. So you might consider some nuancing of that. I think probably the balance is between the two, like in most things. Stick with the schizophrenia criteria, but specify the age, and that is probably, at the moment anyway, the best way to go. I think, like Kraepelin, over time we'll become better at understanding the neurobiology, the genetics, the combination of different factors. Proteomics is sort of quite exciting now in terms of some of these markers, that these might lead us to a proper biological underpinnings of these disorders, and then being able to subtype them. At the moment, my pragmatic approach has been to specify this very late onset group as very late onset schizophrenia-like psychoses, which is pretty much the term which has been adopted internationally now. And again, credit to people like Rob Howard for pushing that. But it's a great question, and one which one could have a lot of different views about.
Yeah. Thanks, David, for that answer. Just following up on your thought on subtypes being thrown away from DSM, I think the biggest loss is the chance to train people on phenomenology. The little bit of phenomenological training with the subtypes is also dead now, unfortunately. Anyway,
yeah, look, I agree with that completely. And, the fact that also the APA have moved away from the prominence of Schneiderian first-rank symptoms. I mean, first-rank symptoms were never pathognomonic as schizophrenia, but gee, they're fascinating phenomena. And our trainees now are just not getting the extent of understanding of those phenomena like we used to.
That's true. So thanks for that comment, David. We have some more questions to get through, so I will not interrupt more of your thought process. The next question is on it's moving from the diagnostic systems to neuroscience. So this is from Roberto Limongi. He's a senior research fellow in our imaging group. From a formal neuroscience perspective, how could the computational models shed light on the mechanistic explanations of late onset schizophrenia? He's also congratulating on your great talk.
Thank you very much. Look, it's not a field which I am expert in at all, and someone on the conference can help me out here. That would be very welcome. But we have done some work trying to look at phenomena and how they might group together, and then map with certain other parameters. So, for example, we did. Remember that I showed you PAC-Sham admixture analysis. We did a subtypology as well, looking at using latent class analysis, for example. And what latent class analysis, as you will all be aware, it looks at sort of hidden, unmeasured factors which underpin groupings of well, in this case, phenomena, as in psychotic phenomena. And we did that, and then we could take every individual within the 513 individuals in the Camberwell register and look at other factors associated. And that actually turned out beautifully for us, very, very compelling to my mind, showed very clearly the early onset group in particular. So with a lot of negative symptoms, formal thought disorder plus psychotic phenomena. And that then, if you put those together, that latent class carried risk for family history of schizophrenia, obstetric complications, poor premorbid IQ, poor premorbid functioning. So beautiful delineation of the neurodevelopmental subtype. There were two other subtypes which came out of that latent class analysis, which again roughly equated with the stuff I've been talking to you about. I didn't share, I should have actually probably shared those data, so thanks for the question, for reminding me to talk about it. I think those models are really fun. Part of the problem with any of these models isn't it that you only get out of it what you put into it. I mean, going back to Peter Little, he looked at what you get out of the phenomena, the way things factor, if you put in a whole lot of phenomena, and showed reality distortion, the formal thought disorder type, the negative symptom type. Of course, he made the point that if you put in a whole lot of other phenomena, you'd get other things out as well, including depression, anxiety. So all modeling needs to be aware of those constraints. And if you're aware of those constraints, then it can be very powerful. But if someone else wants to pick up on the question, because mathematical modeling is becoming much more powerful now.
Great, thanks for that, David. I'm sure you and Roberto can have more discussions on those things later on. The next question is actually a clarification, David. This is, could you review once again what you said about D2 receptors and the aging female versus aging male brain?
Yeah, now this is based in fact, but I've extended, as I said at the time, it's quite a long bow to draw. But if you look at D2 receptor, just sheer numbers as a reflection of brain size, males tend to start off with more D2 receptors in particular than females, but they tend to lose them quicker. So if you look at the trajectory, it's like this, whereas females is a much slower loss trajectory. Now, this is at a very superficial level, if you like. And then I was trying to understand why females had this very late onset disorder. As I said, it couldn't be due just to removal of estrogen because this is happening after the age of 60. So what else could it be? And an obvious candidate when you're talking about psychotic phenomena, obviously, is dopamine system, although it's not everything, of course. And we know dopamine blockers work, as I've shown you with amisulpride. So presumably there's some difference in male and female brains in terms of the distribution and function of dopamine systems late in life. So I was just trying to build some sort of parsimonious model. Could be a straw man which somebody could cut down.
Thank you for that clarification, David. That question was from Lauren Musson. Thank you very much for clarifying that. Next one is from Julio Martinez Trujillo. He's one of our neuroscientists at Robots. His question is on, could you explain whether there is a correlation between hormonal profiles, like estrogen levels, and late onset disease in females? How does the correlation look like? I think you answered some of it, but I think it's a deeper diving question.
Yeah, well, there isn't. This is one of the problems for the field. So if you go back to people like Heinz Hafner, who I should say is a very valued colleague and still firing on all cylinders in Mannheim, he did a lot of work on the epidemiology of schizophrenia. He did a big study called the ABC study, looked excruciating detail at developmental trajectories and so forth. And he then made these assumptions, I suppose, that because females had a midlife peak, that was due to estrogens and menopause. A couple of things around that is they haven't actually looked at an individual level the correlates of and the associations and the temporal sequencing of estrogens and the evolution of these particular sets of symptoms. And although you could spin this sort of idea for midlife, it doesn't seem to wash for very late life because you don't have much estrogen left in your 60s or 70s or 80s or 90s. And that's why I'm reverting to trying to understand it at the dopamine receptor level. However, others believe in the estrogen hypothesis and say, well, females are protected to some degree from early onset schizophrenia because of estrogens. There's been some studies from Jayashri Kulkarni here in Melbourne in particular, looking at estrogen as an add-on treatment for psychotic disorders, and it has some antipsychotic properties. And that's for both females and males. By the way, they've done some studies in males. They're not very. They don't. My reading of the literature is they're not very specific. They tend to be more in the realm of distress and mood than core psychotic phenomena, although PAN score reduces to some degree as well, but not in a very specific way. And also it's not necessarily very enduring. And of course, using estrogens is troublesome in terms of side effects, uterine cancer and so forth. They have done some work which is quite interesting with using SERMs, so the selective modulators, the estrogen receptors, and those seem also to have some benefits. Again, we need very long-term studies and we need to look at risk-benefit.
Great, thanks for that, David. The next question is from Dr. Jeff Rees, who's a psychiatrist. There are two parts to the question. I'll read the first one and then I'll ask the second after that.
I remember, I have a male brain, so I can only deal with one piece of information at a time.
Same here, David. So the first question is, I noted that in regard to the new onset incidence between females and males, the older the cutoff, the greater the relative female preponderance. To what extent has this been corrected for the large number of living females to males in older ages?
Yeah, look, great question. Absolutely good epidemiological question, and they are corrected. It's a very, very good question. Yeah. But if you look at just going back, just looking at the raw numbers, I mean, the excess of females in terms of just longevity, that's undoubtedly there, but that may be, 2 to 1 or 3 to 1. Here it's, 25 to 1. So it's of a different order. But in our population-based studies, we absolutely corrected for that, yeah. And that's one of the strengths of our studies. It's not just the Campbell studies, that is.
Yeah. Thanks, David, for that clarification. The next question from Jeffries is, it's a bit of a piece of Canadian history for you. There was a well-known Canadian psychiatrist named Alistair Munro.
From Dalhousie.
Who promoted Pimozide for late onset paranoia.
Yeah.
So
Yeah,
What's the current thoughts on Pimozide for late onset?
yeah. Actually, I used to quote Alistair Munro quite a lot. I think he's Scottish originally, and landed up in Dalhousie, I think, Nova Scotia anyway. So I know him from a slightly different angle, I should say, because he was using Pimozide for the monosymptomatic hypochondriacal states, and in those days included body dysmorphic disorder amongst them, and I have an interest in body dysmorphic disorder, so I know his work quite well. Pimozide, we don't have it anymore in Australia. I don't know if you still have it there. It's a curious medication in that it's basically an antipsychotic, but is very, very long acting. And some people used to use it as a sort of oral depot. You just need to take it once a week. But it has quite a nasty profile for cardiac QTC prolongation. So we don't have it anymore. Do you have it still in Canada? I don't know. But Alistair Munro loved it, didn't he? He gave it to everyone. I don't think there's anything specific about it personally, other than the very long half-life. Nowadays, we would tend to use, risperidone is quite commonly used, even in the elderly. I'm really keen on the partial agonists, so brexpiprazole, although there hasn't been many studies in very late life, but there's no reason to suspect it shouldn't be pretty benign. My general rubric in prescribing is primum non nocere, so first do no harm. And if you can prevent people dying from QTC prolongation, getting hyperprolactinemia from D2 blockade in the pineal, in the pituitary, prevent them gaining an awful lot of weight with metabolic, and prevent them getting tardive dyskinesia, I think you're doing pretty well. And of course, being female and being older, big risk for tardive dyskinesia. I think the partial agonists deserve a proper trial in late onset schizophrenia.
Pimozide and amisulpride, they're available, but not easily available in Canada. So you have to get special, applications and all that.
Yeah, we don't use Pimozide at all. I've never seen it prescribed. And amisulpride we use actually quite a lot. Europe, it's ubiquitously used, and even in the optimized study, Rene Khan study, they showed it and olanzapine might have an edge over other things. The problem with amisulpride is hyperprolactinemia, and that is associated, as you guys would know, with increased bone mineral turnover. And people with schizophrenia have poor bone health anyway, because of nutritional things, low vitamin D, low calcium, low high impact exercise. So you've already got people with vulnerable bones. You go back to the premise of first do no harm. Why make it worse by giving them a prolactin elevating drug?
So that's great. Thanks, David. There's a number of messages congratulating you and thanking you for your talk.
Thank you
I'm
very
scrolling
much.
through them, and I missed one question earlier, so I'll go back to that. This is from Angelica Silva. She's a language researcher working with the psychosis team here.
Oh, great.
The question is on two questions. One is on any differences between gender regarding the language issue in psychosis. Comment on that.
Yeah. Oh, what a wonderful question. And the simple answer is I don't know, but it would be so nice and interesting to do. In terms of language structure, so the form of thought, I said late onsets tend not to have any formal thought disorder. In younger patients, whether there's much difference across the genders, I don't know, but it's a lovely question. Clinically, I would have thought I can't say that it sticks out to me. Of course, one of the best thinkers in schizophrenia research of the latter half of last century was Tim Crow, who I think just incredible contributions, including positive and negative symptoms, which he described initially. But he also later developed a very interesting theory about language and schizophrenia, and I'm sure you know this, but it probably bears repeating, is linkage of left hemisphere dysfunction and language problems. If you think about a lot of the impact of schizophrenia is about language. And he also then asked the question as to why is schizophrenia still with us, and why is it so ubiquitous across the globe? I mean, it varies a little bit in prevalence and incidence, but largely occurs in every known human society. Why would we have a disorder which can reduce fertility and fecundity? Why would it persist in the gene pool? And he came to this idea about there being a particular point in human evolution, which there was a development of left hemisphere and left hemisphere functions and language as a particularly human thing, and vulnerability to psychotic disorders. He linked it also to the pseudo-autosomal locus on the Y chromosome, sorry, which was very interesting and what hasn't been upheld. But Tim's such an innovative thinker, it's really worth going back to read some of those things. There's a nice paper of his, I think in 1988 or 1989, in the British Journal of Psychiatry, expostulating this. You probably know it, but if you haven't seen it, you should have a look at it.
So, our group here, we do some work following up on Tim's ideas. Tim says language, schizophrenia is the price Homo sapiens pay for language.
For language, that's right, that's right. Yeah.
The question is, do women pay that price less than men in early age, and do they pay more later on in their life? It's a very
yeah. Well, of course, I mean, I know this is not correct politically now to say, but male and female brains are very different from each other. Certainly lateralization is very different. Females tend to have much more bilaterally innervated brains generally. Male brains generally are more asymmetrical in terms of their distributions, and that makes the left hemisphere particularly vulnerable.
Thanks for that, David, and interesting comments following that question. There's one more question Angelica raised, and that's about suicidality. Is there more suicidality in old age psychosis? Could we expect that?
The real risk for suicidality in the literature and also in my clinical experience is in the youngsters, early phase schizophrenia, often at the end of a first episode or the beginning of a second episode. And I think partly that gets sometimes a sort of post-psychotic depression, as it used to be called, or sometimes they get through the first episode and then are just sort of regrouping their lives, and then start to see the onset of a second episode and think they can't cope with it and kill themselves. It's a tragedy, of course. Once you're through that, the suicide rates, suicide excess still continues, but at a much less elevated or inflated level, and is much more associated with depression. The very late onsets, again, because they're fairly rare and suicide is a rare outcome, epidemiologically that is, still a tragic outcome, of course. I'm not sure that there are any systematic studies, I stand to be corrected, but I'm pretty confident about that, of suicide. That is not usually something which is majorly on people's books. People, again, my experience is if you, highly paranoid in a very contained way, but you can still sort of function, and that's what the late onset people have, you tend to actually be protecting yourself in a way. You're protecting yourself against the world. Sometimes what you do see is when you treat them and they sort of gain insight and they realize how their lives have been disrupted by this, they can really become quite depressed and demoralized, and you need to look for that. So that might be a particular risk time, but it's not a major signal in the literature or in my clinical experience.
Thanks.
Not to say it doesn't happen.
Yeah. There are a lot more comments thanking you, especially for the phenomenology, the emphasis you put on phenomenology in the talk. I think a lot of people really like that. Right. So I have a question, and I was waiting until every other question is run down. We have a number of people in the audience who work mostly in the early intervention side, in the younger folks with psychosis. So, I mean, this is somewhat of a question for which you may not have a conclusive answer, but it's an interesting area following up on your talk. Do you think we should treat men differently from women when they have the first episode of psychosis?
Well, I suppose the answer has to be yes, in the sense that how you are in terms of your physiology and your brain, but more importantly, socioculturally, should undoubtedly be brought into a full, proper formulation and understanding of the person's particular context and their particular needs. Also, there are differences, as Mary Siemens said, in dosing of medications and requirements for medications. I mean, it's a real shame for the field that, oh, I'm just going to warn you now, I have a 3-year-old and he's just woken up, so he might have to come and meet you all.
He's welcome.
Hello now. Yeah, it's just coming through. Sorry, this is one of the hazards of doing stuff from home.
You're very used to this, David. No worries.
Hello. Okay. So in those senses, yes, I mean, it's one of the factors which you keep in your mind when you are looking at individualized, personalized treatment. Of course, we also now have a lot of people who identify as the other gender. That's a particular group as well. We need to be very cognizant of them because they have very particular needs. Mm-hmm. But both at a physiological level, medication requirement level, a side effect propensity level, dosing level of meds, and also different side effects might be tolerated or not tolerated by males or females differentially. So, I'm very keen on this sort of shared decision-making idea and saying, I'm not, as a male, old white male, I'm not going to make assumptions about what you value or don't value in terms of, or are prepared to tolerate in terms of side effects. It's not for me to make that decision. I need to understand that this is the range of medications. These are the likely side effects with this or with that. I mean, some people, won't countenance anything which might cause weight gain, for example. Yeah. Other people say, well, that's not the biggest disaster. And, there's no value judgment about that. It's just what their preference is. And if you don't go through that properly and give them the opportunity, then you're doing them a disservice, and you're doing yourself a disservice because you get all the lovely richness of human diversity in that discussion.
Thanks, David. It was a fascinating talk. It's a lot of material and a lot of interesting questions. Thanks for engaging us all this 90 minutes. I think one thing that really leaps out for me from your talk is sex is a very important variable. We talk about personalized medicine a lot these days, but sex offers itself to personalize your treatments so much and your diagnosis so much, but we don't use it appropriately. I think it's time for us to rethink this concept.
Yeah. Well, look, thank you so much, and thanks for the opportunity, and lovely to meet you all, and I'll hopefully meet you in person soon.
Yeah. We welcome you to London, Ontario very soon. Thank you very much. Please join me in thanking David. And the recording of this will be available soon, and I will email everyone about that. Thank you very much for joining us today.
No problem. Thank you so much.